on trauma-informed care, what we're calling 1.0. And then I'm going to turn it over to Dana, who's going to talk about trauma-informed care 2.0. And so one of the things that we spent a lot of time on in trauma-informed care was launching ACEs screening beyond the infant parent dyadic ACEs screening, right? So trying to screen older children in the practices. And so what we got feedback on, and what specific medical directors that I'm thinking of was like Dr. Cleric from university, but we also heard from a lot of internal medicine practices. We've been getting feedback from Teresa's transformation team at FCC and Peter Bellamarich at CFCC, that they have concerns about how the ACEs screening is working for older children. And specifically, the question that was posed to the TIC team was, is the ACEs working? So we had to operationalize that. And I'm jumping ahead a little bit, but this is a slide that Dana has incorporated into our slide deck, which just talks a little bit about trauma-informed care. And so forgive me, I'm actually going to reorient, because as Katie recently pointed out to me, not all of you were here when we started the trauma-informed care program. So we wanted to take an opportunity today to just kind of refresh or just share what the original intention of the program was. So SAMHSA defines trauma-informed care. It's basically a delivery system model, not really intended for us. It's for everyone else in the healthcare system, for the PSRs, for the PCPs, for the nurses, for the security guards, because what ended up happening is, we are all trained in trauma treatments, but that doesn't mean that our patients in the waiting room aren't potentially getting triggered by our colleagues. So I've had a patient who overheard the PSRs talking about women who have multiple kids by different fathers. In Spanish, the PSR is assuming she didn't speak Spanish or understand Spanish, and then she comes to my session, right? I go to the waiting room, I bring her back, and she's all upset, and she's all triggered. And I think we probably all can have stories of things like that happening in our practices. And so in large part, TIC was developed in part to help change the culture of the practice, the behaviors of the workforce, in order to improve the patient experience, right? So our 3-part plan was training our clinic teams, and many of you played a really critical role in that. Many of you are going to continue to play a critical role in that, but I'll leave that to Dana to share. And then we also realized that number 3, taking care of your clinical staff, was utterly important. We work in the Bronx. We work in Lower Westchester County. There's a lot of potentially traumatic events that our teams get exposed to. And so the development of the critical incident management team was in response to that, because we sometimes, just through our normal everyday work, get exposed to things that can develop trauma symptoms in us. But then we also wanted to implement a type of trauma screening, right? And at Montefiore, we use the ACEs. And we really wanted to do this from birth to geriatrics. So initially, we did PDSAs. We did one at FCC Pediatrics. We did a whole bunch in internal medicine and family medicine practices. And these are some of the lessons that we learned. We learned that when you're rolling out ACEs, a BHIP provider needs to be physically on site. This is more in the beginning because the practice just has a lot of anxiety. We also learned that ACEs screening really should be done at annual physical visits and not at sick visits, just like a lot of our other behavioral health screens. And then also that we only enter the patient's total ACEs score, right, and not the specific adverse childhood events. Other must-have lessons, right, was the cover letter. That ACEs questions should never be read. We don't recommend that family members read it to someone if there's like a literacy issue or a language issue, because these questions are too private and intimate. And so our workflows on the adult side is that patients complete it on themselves, and on the pediatric side that the parents complete it on the child, regardless of the child's age. And there was definitely back and forth around this. You know, a lot of people asked us, well, teenagers can report on their own ACEs. And our logic in asking parents to report initially was that there are things that happen to you between the ages of birth to 3 that most of us have no memories of, but that the toxic stress science shows us is incredibly impactful for brain development. And so we thought it was important for parents to be reporting because the child may have no memory of those experiences. So these are the flexible components, right? Who administers the ACEs screen? How will it be explained to the patient? Who puts the total score in EPIC? In most of the practices, it's the nurse. And then who conducts the follow-up? In most of the practices, it's the PCP. Strong recommendations was to allow patients to complete it in a private area to increase feelings of safety. That's not always possible given the physical layout of your practice. And you know that we really wanted the PCPs doing the follow-up and then referring to BHIP if necessary. So this is kind of what I alluded to earlier, right? We got asked this question, like, is it working? And so the way we operationalize this is we asked, is the ACEs screening helping us identify patients at risk that other behavioral health measures are not already identifying? Raise your hand if there is screening fatigue at your practice. Yeah, I'm shocked I don't see everybody's hand raised. Okay, there you go. So, screening fatigue is real. And we have to demonstrate that what we're asking our colleagues to do is adding to patient health or identifying patients at risk, you know, in other words, that it's worth doing. And we took that seriously. So what we did is we had a sample of 21,000 ACEs given in MMG after we launched the TIC initiative, and that was about a year. We also pulled from EPIC other behavioral health screens given to the patients in the same time period. And so we dichotomized all of these screens either into positive or negative according to the clinical cutoff. Right? So for ACEs, that was 4 or higher. And then, you know, the ASQs, the PSC-17, the PHQ-2, the GAD-2, right? So we used all what the clinical cutoffs were, and we either made it positive or negative. We used chi-square tests to identify the proportion of patients who were basically positive on the ACEs, but negative on the other behavioral health screen. Because remember, our question is the ACEs identifying patients potentially at risk that other measures are not? So for example, a patient who was given the ACEs and the PHQ-2 at the same visit, right, so that would be an adult, and they scored a 4 higher on the ACEs, but a 0 on the PHQ-2. So this would also be like for the PSC-17, they got like an 8 on the PSC-17 total score, but maybe they got a 4 on the ACEs. So I'm going to show you the results both for adult and peds because I think it's interesting to compare the two. So what we basically found in the internal medicine practices is that the ACEs is identifying a significant amount of the population that the PHQ-2, the GAD-2, and the alcohol question is not picking up on. And it ranged from, 8 to 9%. So at MMG, we have 210,000 patients that are adults. So you extrapolate that, and that's a lot of patients, potentially, right? Around 90,000 if everybody went to get their health maintenance visit. At the family medicine practices for adults, this was even higher. Between 17 to 19% of adults were scoring 4 or higher on the ACEs, but they were scoring 0 on the PHQ-2, the GAD-2, or the alcohol question. Now we go to pediatrics. Totally the opposite pattern. The ACEs was not substantially identifying kids that the other behavioral health measures were not already picking up on. So in the, kind of birth to 5 healthy steps age, didn't even hit 1%. And for our older kids, even though technically we started doing the PSC 17 at age 4, it was around 3%. Christina?
And this is for parent and child age 4?
Oh, thank you for asking that question. This sample for pediatrics only includes ACEs beginning at age 1. It does not include the infant parent dyadic ACEs. The trauma-informed care program, kind of our mission was to get ACEs screening up and running from age 1 and older. The infant parent dyadic screening, that was well established and supposed to be best practice regardless. So this does not include the babies. Although, if you've looked at the baby data, you will note that most of the babies are not at a 4. It's their parents, right? The way we get infants into the comprehensive services is through the adult. It's not through the baby. And thank God, right? It's like you're 3 months old and you already have an ACE score of 4. So, yeah, go ahead, Alba.
If you separate teenagers and little kids, do you see?
We did not do that. We did not separate teenagers and little kids. That's an interesting question. I don't think we would see much of a difference, but that's an interesting question. So, our initial conclusions is that with the adult patients in internal medicine and family medicine practices, ACEs screening is working, right? It's definitely identifying a subgroup of adult patients that the other behavioral health measures are not picking up on. But with pediatric patients, this is not the case. And so this led us to ask a really important question that I will share with you. I felt incredibly stupid at not having thought of earlier in the process, which is, why in the world are we using a 4 as a cutoff in pediatrics? We are in the business of doing population health. We are in the business of trying to prevent kids from getting to a 4. Why are we using a 4? Why are we waiting until they hit a 4? All the research with ACEs shows that once you hit a 4, your odds of developing poor physical health outcomes and poor mental health outcomes skyrockets. Why aren't we identifying kids at a lower number and then giving the parents some psychoeducation, right, about what the ACEs is, the role of toxic stress, and doing a more preventative visit? So we took a look at what would happen if we'd lowered the cutoff to a 2. And, obviously the numbers went up. In birth to 5, it ranged from 3 to 6. And with the PS17, it jumped to 12%. And so where that leaves us is we want to do some PDSAs, lowering the ACEs cutoff to a 2, giving some scripts to the PCPs so that they can provide that psychoeducation to parents about what this means. For those of you that know Nicole Brown, she's apparently been doing this for years. She just does it on her own. She always talks to parents about what an ACEs score represents, regardless of what the score is for the child. And so with her help, we're developing some scripts, and we want to try to PDSA this. I believe Teresa is going to be trying to do this at FCC. Last I heard, FCC is interested in doing this, and so I think for those of you at other practices, I would love to take a few minutes now to hear your feedback if you've been hearing frustration with the ACEs, and do you think your practice might be kind of ready to try a different approach? Anjali?
They asked me and asked her somewhat recently, why is the score 4? We don't have a lot of 4s. Do you think we should make the score 3 or 2?
They're way ahead of the curve.
We're doing it at 4 because that's what I was told to do.
Please email us.
Annie?
The original Healthy Steps study of the data that was analyzed showed that when the parent ACEs at least was a 4 above, then the Healthy Steps intensive services was effective versus when it was below, there was no difference between groups. So that was my assumption about the meaning of 4.
Right, but even in that research study, it was the parental ACEs, not the child ACEs.
This may be, I don't know, but what I has always said that the item analysis research on the ACEs measure itself doesn't necessarily indicate anything after 4 is particularly critical, but at 4 is where you start to see people differentiate between having significant health issues and minor health issues. So that seems to be the number that bursts the bubble.
Absolutely.
That 4 is such a terrible number. Why would we ever wait to see a kid get to a 4 as part of the referral process? So if the idea of screening is prevention and to capture things that kids are experiencing, if it's a 2, then we definitely need to get on board and have that conversation. If I had my druthers, that would be a 1. But as I think through it, a lot of our parents, and at least the families that we have at my clinic, they would get a 1 for having a member in the household incarcerated. I feel like that might be like 70%. Divorce, right?
That's 60% of the population is divorced.
Right,
Yeah.
so that's going to give you a 1, but the 2 starts to add a little bit more to it. But if I still would like a 1 to be, but we have to hire like triple the staff.
Paulina?
Yeah, I'm just thinking there's also research that shows that half of all ACEs are accrued by the age of 3. So I think that might be an important, if we're thinking of we have 2 by the age of 3, can that be predictive of 4 by the time they're 18? You know what I mean? So that might be kind of another rationale for lowering it.
Mm-hmm. So that is what we're going to be. Oh, sorry, Katie?
One other thing is that we know from the resiliency research too that when someone experiences a higher number of ACEs, if they have someone in their life that was supportive to them, the outcomes are better. So for the spirit of prevention and resilience, we're able to catch them earlier and then do some of that resiliency work with the parent to help them be that person, or even as the doctor or the provider in the office, to help be that resiliency factor for that child. It can also lead to better outcomes.
So another PDSA that we want to test out is that, let's say there's an ACEs score of 2, and then a referral is made to our team, and then we develop a really kind of psycho-ed / resiliency, 1 session, right? Where you're just providing that education on toxic stress, the link to long-term outcomes, and here are some resiliency practices, right, that you may already be doing, and you can add a few more to help protect your child from accruing more ACEs. And so Dana is going to be leading that as part of TIC 2.0, right, to do these kind of experiments through PDSAs. Oh, a third one that we want to test is also doing the dyadic approach, so having parents report on their ACEs in addition to their child for probably birth through 5, like in part because of that study that Paulina just cited. That it might be a better way to identify the kids at risk.
Is there
Alba?
any way to control for underreporting?
There is no way to control for underreporting. I think we all suspect that parents are underreporting. I have heard qualitatively PCPs tell me that once the door is closed and they start talking to the parents, all of a sudden all these ACEs come out and that the parent had put a 0. So,
I
yeah.
think it's a really provocative thing to think about. So recently someone asked me, well, if that does happen, the scenario Miguelina is discussing, should the PCP then go, oh, well, maybe you should refill out your ACEs? I think that's really dangerous water to go down because like parents underreport for a reason. And so if we can create a safe environment and connect them to services and booster their resiliency, like that's what we want. And so if their ACE report is not accurate, I mean, it'd be great if it was, but I don't want science to take away from the heart of the matter. And I think sometimes in the literature, because we do think people are underreporting, sometimes that part of it can get muddled. And so that's always my caution around the underreporting dialogue.
I was thinking more when whoever asked you this question originally, if you discuss that with them, when you're giving why there might be a difference between adults and kids.
I think the feedback I've gotten, and Raquel chime in, is just, I think the PCPs have just observed that there's just not a lot of kids who are scoring a 4. And they're not wrong about that. The data is supporting that. And so this doesn't make sense. You know, people are tired. There's screening fatigue. So if we're going to be asking our clinics to do something, we need to demonstrate that it works, or we need to demonstrate that it's for preventative purposes, right? And then if we're doing ACEs yearly, we can track kids' ACEs over time, right? So we'll be able to say quantitatively, you know, this % of kids at this age have these many ACEs, and then when we screen them repeatedly over years, this is what the score is. Yes, Christina?
Just wondering about I'm all for screening for parent ACEs, but I'm wondering, like, would we need to keep screening for kids under 5? Because unless a parent is under 18, their score they really only need to get 1.
Correct, right. So, I hope you guys saw my email about the debacle of the BPAs and ACEs. So we did develop a parent BPA, which should be turned off after there's a parent score for that child. Right? Like that's the way it works. That's why we're trying to create these BPAs. I think the challenge will be, and I do not know of a way around this, if a parent has multiple children, they are going to be given the ACEs more than once. That'll happen even if they have a new infant, right? Because there's no way to link siblings' medical records together. So I don't have a workaround around that.
BPA will come on for new patients too that are under 5.
So we created BPAs from birth to 5, but there are concerns about making them live for children 1, 2, 3, 4, 5 years old because we haven't figured out the right protocol, which I agree with, right? Like we shouldn't be rolling out BPAs if we're still establishing what the recommended workflow is. So once we do these PDSAs and we have some more confidence in lowering the cutoff number and or expanding it to parents of older kids, then we'll revisit the BPAs for the older kids. Go ahead.
This is kind of just looking a little more in the future. If we do lower that number to 2, and you are part-time at a site, would it be a good idea to kind of somehow create Anjali, you sometimes send out letters to families, like you don't get in touch with and things like that, because it would be hard to kind of reach all these families, let's say they went for a 2-month visit, to kind of send a letter out with some of that script that you're making of like,
sure,
this is what you filled out, this is what can happen if you want some support, I'm here. So just feel like
that sounds like a great PDSA to me.
So getting in touch with all those families and just, I don't even know how that would happen.
So the goal would be that we would do a PDSA at different types of sites rather than just one particular, and then that determines how it goes at all the sites. So at a larger site, that might not necessarily be the workflow because of the amount of letters, might be too much to send.
Right,
but at
right.
a smaller site, that might make more sense because you're going to miss more patients.
Right.
And so the idea would be to figure out what's the best type of workflow. And that's why we have kind of the must-haves, and then there's additional categories of like suggestions and recommendations, and then you can kind of personalize it to your clinic's needs.
Christina?
So some slightly unrelated, but I just want to I guess put it out there since you guys are working out the child ACE stuff. So we pretty recently at CHCC started actually doing child ACEs for 4 and 11-year-olds, and I've been getting more questions from PCPs about the fact that they're de-identified, and the PCP is feeling like they need to know which ACEs there are, and kind of, I guess, I think I try to explain it as best as possible, but I think it's also tricky because it's their patient and they feel like they want to follow up and ask the parent which things happened and should I know about this, and I'm just I just wanted to put it out there.
Yeah.
I think this is a great question to raise. One of the things that we bring up, and we'll transition into this in the 2.0, is what does it look like sustainability and continued training. So those are things that we discussed in the first wave of trainings, that people are not to be investigators of patients' ACEs and then go through and then try and identify so then they can see if they need to call ACS and all of those things. And it should not replace clinical judgment. And so at our clinic, I've definitely talked with Dr. Rich about that, and that idea that you're not supposed to go, oh, there's 4, well, which 4? And then you're now a detective and not an MD. And so I think part of that has to do with ongoing repeated training to remind people what is ACEs about and how do we support our family.
And I also think in answer to that question that we also got many times during the rollout is I cite the literature, which shows, and this is hard to believe, but the research shows it does not matter which 4 ACEs you have. They did the analysis and sliced it and diced it all kinds of ways. It is the cumulative impact of the stress and the trauma that is most concerning. And I think, MDs like research study, when you can cite the literature, I think that can also lower their anxiety. Tamar?
I guess sort of the opposite question to that I've gotten is they're not supposed to say what ACEs they got, but a lot of times they'll stay next to it, they'll make a check, or they'll write yes or no next to them, right? And then, and then so patients, so physicians are wondering well, does that make us, are we mandated to report if they checked up that the child had sexual abuse or physical abuse, or, I guess my feeling would be that if they can sort of explore it if they feel like it's clinically relevant, but I don't know if we have any sort of guidance or protocol for that.
Yeah, so they're mandated to do a full examination and evaluation if they have clinical concerns. So if they look at a paper and they see sexual abuse on there and circled and checked, it's not based on that paper that they're going to say that ACS, this parent put a check somewhere. It would be based on the conversation and the concern. And so I think no screener is ever going to replace human interaction.
Yeah, I agree. Patients are going to, if anything, I would interpret that as a communication from the patient, right? I mean, there's a lot of people who decline the ACEs, and then you have the other scenario where they're giving even more information than we're asking. This is why we do this. We're opening the door because we know that when you come to primary care, it's not just your physical health that matters, it's also your emotional health. And so that's an invitation. I mean, I would interpret that as a communication, right? And then to follow up on that. So how are we on time, Dana?
About 15 minutes left for 2.0.
Oh, okay. So let's transition. Oh, any other questions? This is just the last slide, which I already talked about, that we're going to be conducting some of these PDSAs. So just real quick, this presentation has been given to the executive kind of leadership team at MMG, but we are also trying to get on the agenda for a meeting where all the site administrators and the medical directors go so that we can also, roll this out. But if any of you are feeling pressured at your practices, about ACEs, because I know you go to the transformation team meetings, and if, you're kind of hearing complaints and concerns, I'm more than happy to share this with you. And if you want to give this to your practice, like to kind of get ahead of the curve, but I mean, you can let them know that like we're working to get this presented to them at that meeting where they're all together, but that might take a few months. So just let us know if you want to give this feedback to the leadership at your practice. That's it. Thanks, guys. And that's my thank you slide. There's a lot of people to thank.
Yeah, and I think this is a great, you can keep that one up. Really demonstrates how many people have been involved in TIC. This is our larger group, but I think the bigger piece is that our actual core group is just this group right here. So we're really small. So all of the questions you're having, all of these presentations, trying to manage all of the site's needs and expectations, it's a really small team of us and limited protected time to do it. So if you have questions, if your clinic is like having concerns, please reach out to us and let us know so we can just constantly be making strategies to do that in the most effective way. So I want to talk a bit about TIC 2.0, but I think it's really important to kind of anchor us. We're going to do another training down the road that's for our whole team. We'll talk a little bit more about that as I go on, but I really wanted to just kind of bring the conversation back to like, why are we even doing TIC? Like, why is it important to be trauma informed? It seems like the new hot buzzword. And I think sometimes at MMG, especially with JCO, especially with screenings, especially with these transformation meetings, sometimes we can get away from the heart of why we're here. Like, why are we all psychologists and social workers and psychiatrists? So I always like to present these slides when I go in other places to talk about like, what is the Bronx and Lower Westchester County? And to me, and I'm gonna just dim the light on that because I think the pictures really just speak volumes about the experiences of our patients. So I think about the Bronx as like pride, cultural pride. It's about our bodegas, your favorite bodega, which one you go to and why, families. It's about our kids having fun, getting to be kids. It's about their health and just their daily experiences navigating what it means to live in the Bronx and Lower Westchester County. It's also about sometimes the complicated relationship that our kids have with the police, our parents have with the police, the things that they're seeing on the street. It's their housing. This building, I think, is like, I've seen this type of building a billion times. This picture talking about some of the housing that our kids are living in, the experiences of our families. How sometimes it's so tight and just the living environment isn't necessarily as therapeutic as our own lives are. I also think it's about the art and the beauty and the history of hip hop and pride and advocacy. It's the commutes. I mean, how many of us, just our work experience trying to get to all these meetings, the meetings where, I gotta get how, I got 2 hours in my day that's just gonna be commuting to go to a meeting. It's about the community connecting with each other. And it's also the beach. I tell people the